So first, what I'll do is I'll kind of summarize what we understand about transplantation and COVID. It will take me 3 or 4 minutes, and then I'll be very happy for all the people participating in this webinar to type in their questions, and we have experts, all 4 of us, I guess, who will answer them. Really sorry that Dr. D.S. Rana couldn't join the webinar because of technical reasons, and he was also, I think there was a clash with some media meetings, etc. So basically, as far as transplantation is concerned, it is quite clear that we are not scheduling any routine transplants. We are only doing urgent liver transplants, and my colleagues in the kidney transplant department tell me that they're only doing kidney transplants for patients who have already entered immunomodulation phase for ABO incompatible transplants. So that has to be done. I guess that's a time-bound thing. But otherwise, routine transplants are not being done. Then, what about immunosuppression? Immunosuppression, obviously, there is no evidence of any change needed in the current immunosuppression protocols, either fresh transplants or previously transplanted patients. And it's been pointed out quite correctly that you have to be careful with mycophenolate and azathioprine in case there is cytopenia. That's obvious. COVID infection and post-transplant phase both can have AKI, and then I don't need to tell this audience that you have to be careful with CNIs in that case. Steroids is a mixed thing. I mean, it could deteriorate things in COVID, but there are some reports of high-dose steroids helping the cytokine storm as well. So, as with a lot of medical literature in COVID, it's not very clear at this point in time, but I agree that in general, there are more people not wanting to give steroids than wanting to give steroids to these patients. Now, the other thing is testing. Basically, any transplants you do, the donor and recipient should be tested as near the transplant as possible, because it's possible that you test them like a week before, and then you've got the authorization committee happening, and then you schedule the transplant a few days later, and they could have been negative earlier and test positive later. So ideally, the testing should be done within 24 hours of the transplant, provided the turnaround time in your institution allows that. Then in terms of the professionals, well, I think that people like us who are actively involved with clinical care of patients, if there is a lot of COVID patients in the hospital, it's probably a hospital policy in most hospitals for the professionals to get tested. But certainly if there is a suspicion of contact, or directly if you're taking care of a COVID patient, actually the health professional does need to get tested. The recommended times are 5 and 11 days or 5 and 14 days. I would say loosely, if you can test every week, if you're in the high risk group, then that would be adequate. Then PPE for healthcare professionals. We kind of decided in our Liver Transplant Society of India meeting when we were making the last set of recommendations 4 days ago, that all liver transplants and kidney transplants for that matter, and with the surgical team and the anesthesia team should be wearing a full PPE. Obviously, some people will argue that that may not be needed. N95 especially is a very uncomfortable mask to wear, because you can't really last more than an hour wearing that mask. You kind of sweat and you can't breathe, and that may not be a very comfortable feeling to operate. But what we then decided was that we can take small breaks, but you should still be wearing a full protection. Then I don't think anybody mentioned that, but we, and I'm sure the other hospitals have developed a re-sterilization protocol for N95 masks. We use hot air oven at 70 degrees. It takes about 30 minutes to sterilize them enough to be able to be reused. This is based on a Stanford study. And there are other methods. There is ultraviolet method of re-sterilizing the N95 masks, and there is something called the STERAD. So basically 6 to 10 reuses can be recommended, and each time you're wearing the mask for like up to 4 to 8 hours, like your shift or surgery or whatever. So although the Stanford study, actually they reused it 20 times. But in our hospital, it's recommended to use it 6 to 10 times, depending on how much you're using it each time. Then treatment. Well, the protocol that we are following for treatment is 200 milligrams of hydrochloroquine 3 times a day for 5 days for proven COVID patients who are admitted to hospital, and that goes for transplant and non-transplant patients. We are also following a prophylactic protocol of hydrochloroquine 400 milligrams twice for the first time, and then once a week for the next 11 weeks for healthcare workers directly in contact with COVID patients and who are just fearful or who have occasional contact with unknown status patients. Then they should have 400 milligrams of hydrochloroquine weekly for 12 weeks. As you know, this has been approved for treatment by the FDA. It has been incorporated into the government guidelines, but the evidence for it is not strictly hard scientific data. I guess it can be left to individuals, but more like it can be left to institutions to decide on the treatment, but this is what we follow. Then there was something said about effect on the liver. Well, Abhideep also mentioned that there is a cytokine storm, which is responsible for the ARDS, and in fact, that's why patients have stiff lungs. They go on ICU on the ventilator, and many of them die for that reason. They also have something called multi-organ dysfunction, and the effect on the liver could be a part of the cytokine release syndrome. However, there could be a direct cytopathic effect of the virus. We don't know yet. Then the other thing is that there should be some tweaking of protocols in case patients present with decompensated liver disease. So in the sense that if somebody comes with a fever and they are likely to have it because of an SBP, but you don't know because the results aren't back, or it could be because of bacteremia, again, the results will take 5 days or 3 days to come back, then these patients must be tested for COVID. So known liver disease patients or known end-stage kidney disease patients who come in with an acute decompensation or an acute illness, they should definitely have COVID testing in the present scenario. And then, because there are always overlap symptom signs and laboratory features between decompensation of these patients and COVID infection. That's the reason that they should have COVID testing. Are there any questions that have come from the people participating in the webinar?
Sir, according to you, any deceased donor transplant performed in North India after lockdown?
Yes, I do know of a couple of deceased donor transplants that have been done. But I also know of at least 3 donor offers that have been turned down by our and other centers because their COVID status was not clear. One patient had a clear pneumonia, so we turned it down. And the other case was where COVID testing was not possible in the evening or at night. So again, the donor was turned down. So there was these 3 cases that were turned down, 2 that I know of that have been done in the last 15 days. So in general, I must confess that even though deceased donor organs are a rare commodity, people are turning them down if the COVID status is suspect.
Sir, as per the guideline, we are not able to do COVID testing in asymptomatic population. So when you want to do a life-saving urgent transplant, and if healthcare workers are exposed to the COVID patients, how we can do COVID testing in healthcare workers if they are asymptomatic?
So, look, around where we are in Gurgaon in the Delhi NCR, the current turnaround time is like about 12 hours. You give the sample in the morning, you can get it back at night, but if you give it later in the day, you probably get it back the next day. But the turnaround time, as you all know, is coming down. Literally, with every 2 or 3 days, it's coming down from initially it used to be 4 days, 3 days, 2 days, now a day or less than a day. I would go on to say that if the COVID status of an acute liver failure patient is suspect, then I think we may have to turn down this transplant. I tell you for 2 reasons. One is that it's a risk to healthcare workers. There's a team of 20-25 people who's involved with every transplant. So that's one. The other is that if the patient or the donor turns out to be positive later, then it may even compromise the recipient's survival. So, you will not be doing them a service. So I think for that reason, personally, again, it has to be a decision of the transplant team. I can't really put a diktat for everybody, but I would turn a patient, even with acute liver failure, down if the COVID status is either positive or highly suspect.
Okay, sir, and we can do testing of healthcare worker, patient and donor, but what is about the family members who are taking care of patient and donor? Because they might be having a symptomatic infection. How to take over of this problem?
So there has to be a proper history taken from the family and the patient when they present to the hospital. That's obvious. And if there is a suspicion, you must advise testing, and only if the tests come negative do you proceed. So that's understood. But you're right, there may be some people who slip through the net, who either are not able to give accurate history, or for whatever reason, we don't get that coming straight on us. And it could be a risk to the healthcare workers. That is something that you and I have to live with and make sure that we use enough PPI to prevent that risk.
Sir, can I pinch in? But majority of the patients who acquired infection, when the worldwide data shows 95% patients came with these mild infections.
Yeah.
Only the 5% of the pupils will acquire the severe infection. Out of them, it is possible that your mortality would be 15–16%. So, and there are certain group of the patients who are only so much prone for developing severe infection, cytokine storm-like syndrome, multi-organ involvement, and then death. So here, a quite healthy person who even acquired infections, I think we should just wait for the self-cure. The patient will improve in next 14 days time once the antibody will evolve in this person. So here it comes questions that with the limited availability of the kits, whether the donor, whether this caretaker of the patients should be excluded and should go through these kind of the testings. So definitely it is, I fully agree with you, Dr. Soin, that we should not do any kind of the transplantation right now, particularly in the Delhi regions, who is thought to be one of the epicenter in India, and a lot of patients are coming. But where there is no such patients, I think in the best utilization, I do not know is there any part of India where there is no infection. Right now, I think every part of India has some infection. So ideally, we should not do. But definitely in emergency cases, sometimes it comes with all precautions of testing of the donors, testing of the recipients. We can go ahead with taking all the precautions. So only in emergency situation, not in the regular checkup.
So
I have got.
Let me get a view of the experts today on what you think of home care of COVID positive patients. Dr. Kutte, what is your opinion? Don't you think that if out of 100 positive patients, only 25–30 need hospitalization, the remaining 70–75 should be cared for either at home or in designated isolation facilities if they don't have
home care is possible because majority of the patients are having just mild flu-like illness. So home care is possible.
But I don't think it is currently clearly put down by the government. I mean, every positive patient rushes to the hospital.
So this is the reason why almost all government hospitals are only doing what they are doing there for the whole day. They are doing some testing for these patients. No other works. Everything is locked down. No regular surgery. No other procedures. So I think we should be very much realistic in the sense that whether these normal healthy persons with this only mild symptoms coming with some rhinorrhea kind of things and some mild body ache and manage no too much of the breathlessness, there is no hypoxia, they should be taken care at home. Otherwise, at present it is fine with this much of this 3,000 of the patients. You can do isolation and you can do quarantine in hospital. But if it takes the dynamics of the USA, if it takes the dynamics of USA and UK,
True.
then
Very,
it will be very difficult to take care.
very true. Abhidev, what is your view on home care of COVID patients?
So I'm going to divide these patients into two groups. One is like immunosuppressed and one is the normal. So in non-immunosuppressed, definitely home care. But as far as when we talk about immunosuppressed, yes, ideally I would want to give them all the information and I would want them to be on a telemed connect with me in a home care ideally. But then there are certain things I would want to review on a regular basis so that I know I'm not missing a window of opportunity where I need to modify their medicines. So that is something their follow-up would be more intensive, maybe on a telemedicine thing. But yes, as the overall home care thing is concerned, yes, I am all for home care for these patients. As Dr. Prasad has rightly pointed out, if the number goes really high, we will not have adequate number of beds. And more the people we can keep them at home with mild illness, it is better for the entire healthcare infrastructure because we'll not end up using that many PPEs in that situation. Today only, as you know, there are 108 people in one of the Delhi hospitals have gone on quarantine just because they were exposed to one or two patients. So that is all in the news, as you know. So
Yeah,
that is something would be a big problem.
That is gross misutilization of hospital resources.
Right.
I agree with that. Kunal, you have a word to put in there?
Yeah. Yes, Dr. Soin, there are the question answers live going on. So the audience is asking that is there any common protocol across the country we are preparing for transplant patients?
Okay. The answer to that is there are ISOT guidelines which were presented. There is LTSI guidelines, the Liver Transplantation Society of India. These are all put up on the respective websites. I don't know about, has the ISOT guidelines been put up by the ICMR yet?
No, it is put it on NOTO website.
NOTO website. So there is a NOTO website which carries the ISOT guidelines for transplantation and COVID. And there are, as ICMR website has the liver transplantation guidelines for the same. So yes, there are national guidelines. Next question.
Sir, one audience wants to know about the 2 liver transplant patient, what you turned out.
What do you turn down?
You mean the cadaver?
Yeah.
So the thing is that we were not the only ones to turn it down. It was offered to at least 5 centers, and they all turned them down for the same reasons. In 2 cases, we could not ascertain the COVID status of the donor. And in one case, the donor had a clear-cut pneumonia, which was bilateral and mixed picture of pneumonia and ARDS. So I think that all the teams in their wisdom decided that these donors were not acceptable. You know, there are no hard and fast rules. You have to do these things on case-per-case basis.
Sir, what precautions should be taken after lockdown for the patient and donor? Will you just suggest routine screening of patient or donor, or will you suggest a 14 days isolation for patient and donor before living donor transplant?
So we haven't gone to the extent of suggesting quarantine and isolation for 14 days for every donor and recipient, but we have certainly done that for our foreign patients because obviously they have traveled to India. So we have not transplanted a single foreign patient unless they've had a clear-cut quarantine and isolation for 14 days. And in fact, the 4 or 5 patients that are on our waiting list, we are sending their COVID tests now. And only one of them is urgent. The rest of them have been asked to wait. So the same principles are going to be followed. But we can't do quarantine for every patient before transplant. That's not being done right now.
So that's, I would want to add, that is the only thing being done in Japan. That is one of their society guidelines. And the idea of doing that in Japan was to conserve the COVID testing kits. So what they made is either keep a patient admitted in the hospital for 14 days before the transplant. And then if there are no symptoms, they went ahead and they're doing the transplants active. They're not stopping their transplants.
Yeah. So I would agree with that if you have a policy of proceeding with transplants, then you have to make sure that they are not positive, of course. Now, just a linked question. Let me ask again, one of you, Dr. Narayana Prasad, you tell us, What if the patient tests positive 3 days after transplant? What are you going to do?
Sir, you can just see with all the idea of having seen some of the series of infection in post-transplantation, I don't think every patient would have the same degree of manifestations and every patient is going to deteriorate. What I will do, if our patient is doing well, we will continue with this prednisolone. I will try to reduce the dose of mycophenolate mofetil. We should continue towards the lower dose recommended higher level of the tacrolimus or CNI. So degree of immunosuppression should be optimized. That is the main questions. And we should wait for whether your patient is deteriorating or not, whether your patient has a lower tract involvement or not. It is possible that your patient might be cured without too much of the intervention. It is possible that this patient might have the lung involvement also subsequently. If there is no lung involvement and your patient is doing better and better, by the 7th, most of the times I have seen first 6-7 days usually do have the milder symptoms. Next 6 days, the patients might have the involvement, but 18th day, one of the patient has improved like anything. Whole of the lung, which was serially followed, that has been become normal.
How to identify source of this COVID-19, whether patient was asymptomatic, whether he acquired infection during hospital, or whether donor was asymptomatic. It is very difficult to identify the source.
If well for 3 days, then he developed a patch in the lung, and then next morning he had patches on both sides, and he was tested and he was positive.
Yeah, it is possible that the transmission might happen in both ways. It is possible that we all understand, since we are dealing with the transplantation.
Let's tell how will we treat the patient. So one, Dr. Narayan Prasad said very rightly, don't do anything extra or get too excited. Just see how the patient does, and if he's doing okay, change almost nothing. If there is a cytopenia, reduce the mycophenolate or azathioprine. Fine. Abhidev, any more to add about what is to be done?
Yeah, so giving an example of the similar case, Wuhan case. So what they maintained throughout was a maintained immunosuppression so that there is no chance of rejection where they have to give bigger doses of steroids. So that is something we have to prevent. We should have an adequate immunosuppression, monitoring the lymphocyte counts and overall symptom profile. If symptoms are not worsening, patient is stable, a baseline immunosuppression to be maintained so that rejection-like situation does not come where you end up giving bigger doses of steroids or any other therapies. So
Good.
That is something.
I would add one more thing. I would test all the healthcare professionals all the transplant professionals involved in transplant. I would test both the families. Okay, any more questions, Kunal, from the audience?
One of the important question audience has asked that we have access during the course of treatment, the patient develops.
Your voice is not clear, Kunal. My voice is clear.
After the transplant recipient donor, do you think team should split into two for the start of the transplant? So it is for the transplant unit.
Yeah.
Your voice was not clear. We have not heard you.
I understood the question. I will repeat the question. The question is, you think that for a long transplant, the team should be split in two, and one team should not be exposed for very long. Well, my feeling is the answer is no. I would get the same people to work for 1 day, whether it is doing 2 kidney transplants or a liver transplant or doing 10 endoscopies. I would get the same people to do all the procedures rather than expose different sets of people to the same procedure. However, the people who are operating, the people who are doing the procedure must be fully protected. There is no doubt about that. So if it's a transplant that has gone on for 10 hours, that liver transplants sometimes do, then yes, they should probably have a change of gear after 4 to 6 hours. I would do that, rather than get different people involved and expose them also. Abhidev, what would you do?
I agree. Team should be in such a way that if one is exposed, we should have a backup team to take care of these patients which we are operating. So that is what most of the centers have done. They actually divided their teams into three parts, and their two teams were at home. So it was like a relay race. Like one team, by the time they get exposed, there is a second team who has completed their quarantine period, and then the third team. So that is the best way to actually, so that if you have done a surgery and all of you are exposed and all of you need to be quarantined, there has to be a backup team to take care of these patients.
Good. So divide your teams into 2 and 3, but not for the same patient.
I agree, totally agree with that.
You have people working today, then another set working next week, and so on.
Absolutely.
Questions?
Strategy of our hospital at SCPGI. Our half of the residents are at home, and only half of the residents are working at present. Half of the faculty are working and half are at home. So that in the same way, once any one of us who got infected,
sir, one of the important question asked by audience: what is the legal implications? What is the legal implications when the recipient get the positive COVID-positive after the transplant, when he goes home?
So, so what we have done is there is a specific mention of this in the LTSI guidelines, that there will be an inclusion in the consent where there'll be a disclaimer saying that it is possible that the test done preoperatively could be falsely negative, or the patient is in the window period where they have acquired the infection, but they haven't tested positive. So that is a danger, that's a risk that the patient and the family have to accept. Sorry, Dr. Narayan Prasad, you were saying something?
Yeah, I think I was same thing. I was just trying to explain that it is possible that someone in the incubation period might manifest disease later on. So that much risk, I think a family should understand, and then only with understanding all these risks, we can go ahead.
Any more questions, Kunal, from the audience?
No, sir, no. I've just taken almost all questions.
Okay, so anyone has any last minute thoughts that you want to convey, and then we'll close this session in a minute.
Yeah, so I have already answered almost all questions. 8-10 questions came, so that is already went to them. So
all of
message
is I'd like to thank Kunal and Panesia team for organizing this, Dr. Narayan Prasad, Dr. Kute, and Dr. Abhidip Chaudhary for their valuable contributions, and tell Dr. Rana that we missed him, and we'd like to tell everyone to please stay safe. Make sure your family, and that means extended family, that means your team, your professional team at the hospital, as well as your personal family, they're all safe. Let's all, it's a call to us to be on the front line and do our best for our patients. We will all do that. And like Abhidip and I have said, not just for transplant patients, for every COVID positive patient. And also don't forget, let's try and further some drug trials and research into drugs and vaccines that can solve this problem. So let's all fight this together.
Okay, thank you very much, sir. Thank you, sir. Thank you.
Yeah. No, sir. Almost the questions have completed. We have addressed almost all questions.
Dr. Kunal, offline है online है हम अभी?
Yes, sir.
We are online or offline?
Yeah, we are online. We are online only. Doctors have switched off their camera. We are online.
Okay, so can I leave now?
Yes, sir, you can leave.
Okay, thank you.
Thank you.
Yeah. Thank you. Thank you very much, Dr. Soin. And we will be together to fight against the COVID-19. Thank you very much. Panisha Biotics will be with you all always together.